last 7 episodes, a wonderful response across the country, and this in high demand of this program of our this 2024 IAP action plan. So I welcome Dr. Pramod Jog sir, Dr. Satish Sharma sir, and all the Vice President, Dr. Lalit Mendirattaji, Dr. Singarvelu sir, and Dr. Dr. Basaraj sir is there, Dr. Devendra Mishra is there, Sarin is there. So over to you, Kalpana madam. Please invite Dr. Basaraj sir.
Yes, sir. Thank you, sir, for your kind words and a welcome address. Now I invite our very dynamic, academic, brilliant president, young president of 2024, Dr. Basavaraja, sir. Please welcome to this session. I request Dr. Basavaraja to say a few words about because it's your brainchild program. Dr. Basavaraja, please.
Yeah. Thank you so much, Professor Kalpana. Yeah. Thank you so much, Professor Kalpana Datta, madam. So this is an 8th episode of our academics through the institution. This is one of the innovative program which is focusing on to the postgraduate practitioners and teachers. Today we are fortunate to have an SV Medical College. Cuttack is one of the oldest medical college. With the today's chief guest Prasanjit Mohanty sir and Professor Sunil Agarwal, who is one of the common name in the Indian Academy of Pediatrics, which is synonymous with the academics, whether it is an advisory committee on immunization, whether it is an Indian College of Pediatrics, or any scientific things. Professor Sunil Kumar Agarwal is one who has did a great job. I can see the Professor Swarupa Panda madam also there, and all other Meher ji is there, and all others who has been joined from the Cuttack Medical College, all the faculties and head of the department, and Prabhakar Mishra ji was my co-EB member during my tenure. So thank you very much accepting to be the part of this program. And this is equally supported by our national coordinator, Dr. Priya Shivali. Today with some family function, she is not joined. Dr. Kalpana madam is there, Dr. Lalit Mendiretta, Dr. Keshavalu, and the chief advisor of this program is none other than Dr. Jagdish Chinnappa. So who is always a creative in his thoughts, along with our senior vice president, Dr. Satish Sharma ji, Santanu Dev, and Keshavalu, Professor Singarvelu, Balachandran, Professor Devendra Sarin sir, and our past president, Dr. Pramod Jog. And Neelam ji, welcome after a long time. Neelam ji is joined from this one, and our Amul Pawar. So this is a program which is well coordinated by our secretary, Dr. Yogesh Parikh, along with our finance secretary, Dr. Atanu Badra. So this is a program which has been all the pediatricians are looking for it. So let's look into our SB Medical College, the history and as well as an academics, which is really what the people of India is looking for it. Back to Professor Kalpana madam.
Thank you, Dr. Basavaraja. I would like to say we really badly missed you in our when we had presented our medical college. At that time, we were not there, and we are really missing you all the time.
No, that day there was one meeting, madam. That is the reason.
Yeah, I know. You are you had a pre-assignment meeting, but okay, so all right. Thank you for your visionary words. Now, I would like to invite Dr. Jagdish Chinnappa sir, the chief advisor of this program, to say the concept of this program.
Thank you very much, Dr. Kalpana, and the Central IAP led by Dr. Basavaraja and Dr. Yogesh, and all the other office bearers. I think this program is one of the most exciting programs of the week because we discovered the gems of India, the institutions that have contributed to the growth of pediatrics in this country. And I think the Cuttack Medical College has been one of the oldest in the country, and it has celebrated its platinum jubilee recently. So I think we are going to hear a real feast of academics from this great medical college. And I thank you for giving me this opportunity to say a few words. Thank you, madam.
Thank you, sir. Now I invite our very dynamic, very cordial academic, Dr. Shantanu Dev, VP East Zone. Dr. Shantanu, please introduce chief guest for this program of SCB Cuttack.
Thank you, madam. First of all, good afternoon to our National President Basavaraja sir, Chief Advisor Dr. Jagdish Chinnappa sir, then Dr. Yogesh Parikh, our HSG, Dr. Satish Sharma, Dr. Singaravelu sir, Dr. Pramod Jog also, and whoever is there on this platform. It is my proud privilege to be present here to present or to start off proceedings for one of the oldest medical colleges of our zone. SCB Medical College. I have been there also to conduct ALS courses, and I can see so many known faces sitting there. So it is my very proud privilege to introduce Professor Prasanjit Mohanty. He is a MD of Skin and VD, and he is the Dean and Principal of SCB Medical College, Cuttack. He has teaching experience of more than 30 years, and he has been a professor for more than 12 years. He has numerous publications in national and international journals, more than 40 in fact, and he has also written chapters in many books. He has been a life member of European Academy of Dermatology and Venereology, also Indian Association of Dermatologists, Venereologists and Nephrologists, and he is also a member of Indian Society of Pediatric Dermatology, also Association of Clinical Dermatologists of India, Association of Cutaneous Surgeries, and Indian Medical Association. He has been bestowed with several awards. He received the Valmi Oration in 2018, Harish Mohanty Oration in 2019, Best Teacher Award for IADVL in 2020. He also received the Inspiring Dermatologist of India 2020 award by Economic Times. He is very humble, punctual, workaholic, great clinician, academician, and very popular among staff and his students. I request Mohanty sir to say a few words.
For your kind introduction. I'm indebted to all office bearers of Indian Academy of Pediatrics for inviting me to this online webinar. I'm happy to say that IAP is conducting several workshop meetings TOT for our country children. This time, SCB Medical College, Department of Pediatrics got the opportunity to showcase their activities. For last 3 years, I am acting as the Dean and Principal of this prestigious, one of the oldest and largest government medical colleges of our country, that is SCB Medical College. Our college has 2,500 bed capacity, which is going to expand to 4,000 plus in the near future. The PG Department of Pediatrics and Sishubhawan is known for its best child care and critical care for last 75 years.
I cannot hear your word.
You can't hear. Hello?
Kalpana madam, please mute yourself. Kalpana madam.
It's a center of excellence for FBNC, NRP, IMNCI, ICU, PICO, NHSK, and so many training programs. At present, Superintendent Professor P.K. Jena and HOD Professor Prabhakar Mishra are nicely managing the institute with a common motto for uplifting training and quality childcare. I wish all the best to Central IAP and Department of Pediatrics, SCB and Sishubhawan for a successful academic webinar. Thank you once again to all of you for inviting me. Jai Hind.
Thank you, sir. Thank you so much, sir. Kalpana madam, please unmute.
Thank you, Dr. Prasanjit Mohanty sir, as a chief guest, and your words, kind words, and your visionaries about your college. And thank you, Dr. Shantanu, also for introducing our chief guest. Now, I would like to introduce our chairperson today's program, Dr. Prabhakar Mishra. He is the professor and HOD, Department of Pediatrics and SVP, Postgraduate Institute of Pediatrics and SCB Medical College. In charge of Newborn and High Risk Clinic, he is awarded IAP Zone Pioneer Award in 2010, FIP in 2015, FACE PM in 2015. He is a Central IAP Executive Board member in two terms, 31 years of teaching both in PG and UG students in different medical colleges, trainer in PALS, NALS, NRP, IMNCI, and different government programs, asthma, RCH, critical care, and NTP. Presented a paper in both national and international platforms, more than 60 research papers, published more than 40 research articles in national and international journals, and he has been instrumental in giving academic activities in his college. He's the editor of IGMPO, Pediatric Education Research. He's a member of editorial board of IGCH, IGPP, and IGTEP. Sir, Dr. Prabhakar Mr. Sir, please welcome to this program, and I request you to conduct this program further. I'm handing over this platform to you, sir. Sir, you request introduce Dr. Sunil Agrawala for presenting the history of the medical college for 5 minutes. Sir, you are not audible.
Okay, madam, thanks for your kind introduction. So presently I am the HOD of Pediatrics of this SVPPG Institute of Pediatrics, which is a part of this SCB Medical College, Cuttack. And we have our other professors. Next professor is our Professor Gita and Professor Sunil is there, Professor Sunil Kumar Agrawal. And another professor is there also, Professor Gita Sethi. So all of them are working, doing hard work for this institute of national repute. And we have 24 postgraduates intake from all India. We are taking from the NEET. And I am just showing you a small PPT of our institute and the SCB Medical College. Start. So we are a part of this SCB Medical College. Everybody, myself and Professor Sunil Agrawal and all faculties who are present and participating in this. So the SCB Medical College
Please continue, sir. Please continue.
Okay, sir. So, so this is the oldest medical college which started from the age of Marathas, and here the pilgrims who were visiting for the car festival from long way to Puri, and they were taking rest at Cuttack, and for them the first this hospital was a dispensary, and subsequently to attend to the Sikh pilgrims during car festival. Then subsequently during the British rulers, this dispensary continued to be another hospital, small hospital. Then further it became the Odisha Medical School in 1875, and the then civil surgeon was the first principal of this Cuttack, Dr. William Day Stewart. Then subsequently in 44, Odisha Medical College, school was converted to Odisha Medical College, and Major A.T. Anderson was the civil surgeon of Cuttack, acted as the first principal. So Odisha Medical College was established in June 1944 with a capacity of 22 students in the MBBS degree course to start with. So this was named as Sri Ramchandra Bhanj Medical College, and MCI recognized seats started from 52, and subsequently MDMS courses from 60, and 81 postdoctoral courses like DM and MCH in cardiology and neurosurgery were added. So presently it is affiliated to Odisha University of Health Sciences. Previously it was under Utkal University. So we have 250 undergraduates per a year, and also we have postgraduates 229 of MD and MS, and also 27 master in dental science, and also we have 42 postdoctoral like DM and MSc courses. So all India ranking of this SCB Medical College comes to be 44 as per the National Institutional Ranking Framework of 22. Then these are the students, 250 students, we cater them. This is the final outgoing batch with our dean and principal sitting at the center, the superintendent, and the cardiology HOD, medicine HOD, and all the head of the departments. This is just bye-bye to the final year students who are appearing the exam, and the MD exam is going on now, MBBS exam. So this is our Sardar Vallabhbhai Patel Institute of Pediatrics. This is now under the Mo Sarkar scheme and 5T scheme. Government has given a very good setup, which will provide 7-story building with 846 beds, which will be open up shortly to provide exclusive pediatric care to the children of Eastern India. So everything is free here, including ICU care. Every medicine, every patient comes to the hospital, everything is free. Patient will not have to spend a single pie. And this is our advanced research center of SVPPGIP, followed by the new building. So the Department of Pediatrics started in SCB 60, and this is an extension of Department of Medicine. Then DCH program in 62. Subsequently, MD was added, and SVPPGIP was started in 1966. So this is the Advanced Care and Research Center of SVPPGIP Cuttack, which is a part of sister wing of SCB Medical College. So presently 520 beds, but subsequently it will be extended to 846 beds, and we have this 35 PICU beds, 10 NICU beds, and 150 dedicated newborn care beds in our institute. So this is the Division of Pediatric Nephrology was started, and this is providing services having 17 beds and 2 continuous renal replacement therapy and hemodialysis unit, providing the care to all children of acre and chronic renal failure cases of this eastern zone. So we have also this Pediatric Center of Excellence, which was developed during the COVID, and now it is converted to general care. Then this is the Center of Excellence. These are the all professors who have worked and contributed to the development of this institute. So we have got stressed newborn care resource center, which is providing training to IMNCI, FBNC, facility-based newborn care, newborn stabilizing unit, and a kangaroo mother care, then national NSSK, then this RBSK, NRP, PALS, ALS, critical care, and PICU. We have got, in this new building, we will be expanding our critical care area to 100 beds. So these are this is facility-based integrated management of neonatal and childhood illness, FIMNCI, that is being given to all the doctors and of the state. So this is also, we are giving also KMC, kangaroo mother care, and also family participatory care training. We are also giving training on other cares like facility-based newborn care. We have got bronchoscopy unit, and Dr. Vijay Kumar Meher, who is the professor, who is also looking after it and giving help at emergency hours, those having foreign bodies. Then we have got intensive care unit. We have got also training and this renal replacement therapy going on. This is the critical care area having also renal replacement therapy. We have also POCUS, that is point of care ultrasound, diagnosing difficult case. We have also a CLMC, that is the Comprehensive Lactation Management Unit Center at SCB Medical College, where Dr. Swarupa Panda is in charge, and we are doing a good work in providing breastfeeding opportunity to all the newborn babies. So this is with this, I thank everybody for your time. I thank Professor Basavaraja. I thank Professor Jogesh, Dr. Jogesh Parikh, and also all Shantanu Dev, all people in the CIAP, and Professor Kalpana Datta Madam for giving us the opportunity to showcase our case, and we will have case interesting presentation on academics by Professor Sunil Agarwal, and also 2 of our PG students, Dr. Ashish and Dr. Sweta. So with this, I thank you everybody. I thank our Dean and Principal, Professor Prasanjit Mohanty, for his valuable time to us. Thank you very much. Thank you very much.
Thank you, Mr. Sir. But I'll request you to please introduce. Thank you, sir. But I'll request you to introduce Dr. Sunil Agarwal for his presentations. Dr. Mishra, please.
So Professor Sunil Agarwal is one of my students. So he has I worked in MKCG Medical College, and he worked with me also for 3 years. And presently he has been posted as Professor of Pediatrics at our institute. So he is a very academic person, and he is loved by the postgraduates, and he has been executive board member of the CIAP, and this is the second time. He is the executive board member and he is also a member of the advisory committee of immunization, and also he is active in several online and offline programs of the IAP. So our institute is very happy to receive Professor Sunil Agrawal, the academic person and also a good clinician, to develop further with his services, continued services. So I welcome him to present his talk on an emergency on scrub typhus. In fact, when I went to Barampur, the first case of scrub typhus was detected by me. Then I told all the postgraduates, including Sunil, who was in my unit, that we should do ABCD. E is the exposure, and exposure will lead to the finding of the scar and finding of the bite and stings. You can suspect scrub typhus and treat. Many patients who are being admitted for 2 weeks, 3 weeks, and being given a lot of antibiotics without a diagnosis, we are treated successfully with azithromycin, and the fever went down, and patients recovered in 24 to 36 hours. And many cases who didn't respond to azithromycin, we gave doxycycline. But my preference and first choice is azithromycin. I used to treat. So I was well acquainted with scrub typhus. Then when I went to Barampur in 2015, the first round, I diagnosed 3 cases of scrub typhus being labeled as fever for evaluation, but no diagnosis. Received all antibiotics, and they got that. And after that, there has been sensitization among postgraduates and all faculties, so that they are looking nook and corner to find a scar in scrub typhus. So that is the interesting topic, emerging disease, and Sunil will do his best to present about scrub typhus. Thank you.
So thank you very much. It's my honor to say thanks to my Dean Principal of SCB Medical College and my Head of the Department, Professor Prabhakar Misra, and my all co-faculties and students. Respected dignitaries and stalwarts of Central IAP, and a big salute and namaskar to all of you. Here, I am here to tell an emerging disease, that is scrub typhus. Let's start from a case discussion. This case of 6-year-old male coming to hospital with history of 10 days fever, mild cough and vomiting. There was maculopapular rash, body swelling. If you see, look at the periorbital zone, there is some amount of puffiness is there. Irritability and drowsiness. So, dear doctor, the child was seen by 2 doctors and received amoxicillin 4 days and artemisinin in combination therapy for 3 days and paracetamol. In our area, though malaria is very, very rare, but still very uncommonly we can get malaria as one of the diagnoses. So that's why ACT has been given by the treating physician in the locality. The patient hospitalized at another hospital for 2 days, received IV antibiotic and ceftriaxone, no improvement, and referred to our medical college. So dear doctors, if you see fever was there, I'll tell you fever was there, rash was there, and there was loss of sensorium. So it is a case of neuroinfection. Now Kalpana ma'am will be happy that her liking domain is this case. So now what are the diseases? Cerebral malaria, meningitis, acute encephalitic syndrome. Dengue is unlikely because already 6-7 days has passed, 10 days, scrub encephalopathy. So now on examination, no lymphadenopathy, some pallor, no icterus, throat was normal, rashes was there, maculopapular non-itching rashes, eyes are normal, some buggy swelling were there, heart rate tachycardia, respiratory rate 30 normal, blood pressure normal, and SpO2 94 with room air. Systemic examination, respiratory cardiovascular normal, and per abdomen, there is liver and spleen palpable. The child is drowsy, irritable, no signs of meningeal irritation, no neck stiffness, no conning, no Brzezinski sign. So with this, we thought, narrow down the disease. Whatever disease I have already told here, that we are telling dengue, we have taken out. So what are the disease left? Cerebral malaria, could it be AES, and could it be scrub encephalopathy? Hemoglobin, low, that is 9.2. TLC, that is you see leukocytosis, that is lymphocyte 32. Platelet is 1 lakh to the lower side. That is transaminitis. You see here, that is SGPT and SGOT is a little elevated, but not in thousands, it is in 100. CRP is borderline elevated. ICT for malaria is negative. Creatinine is 1.2. Dengue test is negative. And here there is hypoalbuminemia as one of the negative acute phase reactant. Typhoid came to be negative and IgM scrub came to be positive. So my saying this case to all of you is that now the final diagnosis, which came here as 3DD, ICT negative, it is not AES, and there is scrub encephalopathy because we got IgM scrub positive. Now the message is that immediately we tried our level best after getting IgM scrub positive to see. Just now, our head of the department, Professor Mishra, has told, please do exposure and search for SCHAR. And after that, we have searched for SCHAR and we got a nice SCHAR in the right groin. So this gives an immense importance to this case, that SCHAR searching on the day one is a mandate in each and every case, those who are coming with fever of unknown etiology, or you can say fever without any focus. And here we got SCHAR, but it is a retrospective diagnosis. Since then, in our institute, all postgraduates were tuned to search for SCHAR on the day one. So treatment given IV fluids, IV ceftriaxone, and IV doxy has been given, which has been switched over to oral, no steroids. So my dear doctors, eyes are useless when the mind is blind. So learning point from this case is fever, rash, loss of sensorium, pallor was there, hepatosplenomegaly, SCHAR is present. With clinically, we can make this scrub encephalopathy on the day one. Now here we got our supportive evidence that we also got IgM scrub positive. Now couple of cases from our institute where you have to search and see for SCHAR. This is again another child who is having nice SCHAR below the scrotum. See another child, and this was being missed because of this mali, or what you say, the ring was there in the groin, and because it was there, and on the upper part of the thigh, there is a SCHAR. And the child presented with fever for 7 days. You see, there is a now ulcerative SCHAR in the mid of the neck. On the lateral side, right side, you get SCHAR. You see, there is a axilla. If you don't search this, definitely you miss out your diagnosis. Sometimes hepatosplenomegaly may not be there. Sometimes rash may not be there. It is just low-grade continued fever for 10 days, 11 days, and you are having this SCHAR. So now question comes, you see, this is a small girl child having SCHAR in the genitalia. So here hidden parts, why those SCHARs are present in the hidden parts? It is all because our reflex is there. If in the accessible parts, some bug or mite is going, then definitely that is been driven out. So they are not going to bite and they are not going to inoculate the pathogen into the skin. But here in the inaccessible part, definitely they got sticked into the skin and thereafter they release so much of bacteria or rickettsia into the skin and the journey starts. So this is another SCHAR. At the initial site of mite attachment, this is the SCHAR. Always remember the typical quality of this SCHAR is painless and it mimics like a cigarette burn. And it is considered as pathognomonic of rickettsial disease, only pathognomonic of scrub typhus. So dear doctors, we get rickettsial fever, we get Indian tick typhus, we get spotted fever group, but out of them, the only scrub typhus is being associated with this type of black ulcer, which is mimic like cigarette burn. So it is another, you see, nice SCHAR is there. And to all parts of our country, I want to say now, this rickettsia is not a disease of US, neither a disease of only Sishubhawan triangle. It is a disease of everywhere. Even in our country, all the states and the union territories, they see couple of cases of scrub typhus. And there was epidemic outbreak of scrub typhus for 7 or 8 months back in Odisha. So this is the typical SCHAR, and I have shown you multiple pictures of real cases where SCHAR looks like that. You see at the tip of the penis, and there is a nice SCHAR is there. You see another SCHAR, it is there in the back. And this is very nice SCHAR. It is very nicely that somebody may miss, which is there in the right aspect of the neck. Now coming to why this SCHAR is being formed. This is a zoonotic disease transmitted by a mite. It is a mite-borne disease. And this mite is the adult form. That means the adult form mite gives rise to larval form. And this, the picture shows the larval form of the mite is the arthropod which bites and releases this rickettsia into the lymphatics and blood of human. So that's why this scrub typhus is a rickettsial disease which is being transmitted by the mite-borne. It is the larval form of the mite known as Chigar-borne mite. This is the adult form. This is known as trombiculid mite, and this is the larval form. This is known as Chigar. This is a Chigar-borne. And always we remember that this is a zoonotic disease. Now this adult mite or Chigar, they do continue their cycle by biting rodents, by biting zoonotic population. So they do not never bite human population. But by default, accidental bite by going to the scrub vegetation area, park and everything, there must be any part of the thing. Many a times what happens, they come to us and definitely we have to search if there is a fever, if there is periorbital puffiness, we have to bring DD of scrub typhus into our domain. transmission, no direct transmission from person to person is there. It is not like other, like viral disease, like dengue fever, and it is transmitted from blood bite or mosquito bite. It is not. It is a mite-borne disease, and the trigger is the transmitting arthropod. So scrub typhus, little deep theoretical part caused by intracellular bacteria, which is a proteobacteria, gram-negative. It is otherwise known as Coccobacilli and family Rickettsi. And this family has been separated from the other Rickettsi in the name of genera known as Oriensia, and Oriensia Shishugamushi is the culprit. First isolated in the year of 1879 in Japan, first reported in Himachal Pradesh in 1934. Over the years of near about 90 years, we used to get scrub cases at all parts of the body. Incubation period from the bite of the trigger and development of fever that takes on an average 7 to 10 days. So incidence, an important vector-borne disease, I have already told, North China, Japan and Thailand, then Burma and Bangladesh and India, going to Pakistan and Middle East. This is triangle known as Shishugamushi triangle. But I will tell you, India is one of the biggest hub of this scrub typhus as of now. There are approximately 10 lakh cases each year worldwide. What is the pathogenesis? It attacks. Everybody you know that malaria parasite attack RBC. Similarly, this Coccobacilli, this proteobacteria, this scrub, this is Oriensia Shishugamushi, this bacteria attack endothelium. Now, endothelium is the inner lining of the all vessels. Now, these vessels, because endothelium is attacked, and it attacks the macrophage monocyte system, and sometimes it attacks cardiac myocyte. What happened? Because it causes vasculitis. The most important pathogenesis of this is inoculation. That will form the eschar at the site of inoculation. That will be painless. And that will be drained into the local lymph node, regional lymphadenopathy, which is painful. And from that lymph node, it will go to the lymphatic system, left jugulo-subclavian angle. It goes like that. So tender lymphadenopathy, painless eschar is the hallmark of scrub typhus. Then it spreads in the bloodstream, infective phase. There you get fever and release of inflammatory cytokines and tumor necrosis factor and interleukin 6, 3, 2. All these things are being released more and more in the second week. So second week, we get rashes and all. That is known as phase of vasculitis. That is known as inflammatory phase. First week, it is because of bacteremic phase. Second week is more synonymous with vasculitis. So rickettsia is causing disease due to vasculitis and capillary leak. You all know that dengue fever is famous in the critical phase by doing capillary leak. Similarly, this rickettsia or scrub typhus causes vasculitis and capillary leak, which is the hallmark. So course of the disease, first week, systemic symptoms in the form of fever, lethargy, headache, something like that. Second week is the complications because of the vasculitis. Third week after treatment, the child has to come out from that convalescent. So second week is the inflammatory phase, and that is known as cytokine storm. Complications, there are a lot of complications due to secondary infection or due to secondary damage of multiple organs of the body. GI, it may be vomiting, diarrhea, kidney. Many of the cases of unknown AKI presenting to us, many of them come out to be scrub typhus. Unknowingly, myocarditis. In many times, we have seen post-COVID that MISI is one of the cause of myocarditis and failure. And we got many cases of rickettsial. Acute lung injury, pneumonia, CNS meningoencephalitis. Already I told. So dear doctors, when to suspect? Now my question is that when to suspect? Any febrile child with following clinical features. Classical triad of fever, rash and headache. Then you have to suspect. Eschar, every child who is not, suppose a child is coming with some draining of the pus from the ear and there is high fever and cough. You think of it is otitis media. Any child is having tachypnea and cough. You think of it is pneumonia. Any child is having no focus, any part of the body. There is no burning micturition, no pneumonia, no cough and cold, no viral podums, and there is hepatosplenomegaly, pallor, periorbital puffiness. One has to think that it could be a case of scrub. So lymphadenopathy may be regional or may be systemic. Edema is one of the features. Hepatosplenomegaly, which is another DD of long back, 10, 20 years back. Malaria was the number one. Now scrub encephalopathy is one of the DD causing neuroinfection in our neuroinfection patient. Loss of sensorium and fever of unknown origin. Normally, they do not respond to the normal conventional antibiotic, like what we are using in our day-to-day practice. The lower abdomen, we are using cefixime. Above the abdomen in pneumonia, we are using amoxicillin. They do not respond to that. It is very, very honest request that we have to know fever with rash, fever with black ulcer, or fever with edema. This scrub typhus has to be thought of. Now, dear doctors, you can ask me, how many % cases we are getting eschar? to the tune of 9 to 52%. It may be 1 in 10 or it may be 1 in 2 SCHAR present. But not getting SCHAR is not an exclude that we are not getting this scrub typhus. You have to find out other correlated findings. So here, differential diagnosis, everybody knows there are many infections like tropical disease, malaria, brucella, everything we have to think of. Non-infectious, many a times HLH, leukemia, primary immune deficiency, vasculitis, we have to think of. Now coming to investigation. Blood routine, initial part, lymphopenia, then lymphocytosis. Platelet, low platelet is one of the telltale surrogate marker of scrub typhus. Low platelet, you have to think of two diseases. One is dengue in the first 2 to 3 days, having high hemoglobin, but here hemoglobin will go down, platelet count will be go down. Biochemical examination, I have already shown, in that case, transaminitis. So any indirect markers, if you get like low platelet, leukopenia, and sometimes you get transaminitis, elevated CRP, all those pictures will be there. So last few slides, I'll be telling how to investigate. Well-Felix test is one, where indirect test protease antigen that has to be taken. Indirect immunofluorescence, though it is a gold standard, is very costly and it is available in only few centers across India. And PCR for Orientia Sishubhawan, again, it is on the research point. So gold standard, it is known as immunofluorescent assay, and this test is expensive and not widely available across the country. We are very familiar with this investigation. ELISA, scrub typhus, IgM, scrub typhus, ELISA. Rapid diagnosis, widely used, highly sensitive and specific. And this is the card. You see, this is the control, and this is IgG and IgM. So in cases of this, just like malaria card, we are using combining antigen and antibody. So that's why we have to know whether this is a case of this. So this is the card. That Susugamusi, IgM, IgG, and we have to diagnose very early rapid card test. It takes a result positive within 30 minutes to 1 hour. So coming to treatment part, drug of choice is doxycycline, 2.2 mg per kg BD, maximum 200 mg, 100 mg BD, and the next order of drug of choice is azithromycin. We, with my co-colleague, Professor Prabhakar Mishra, who have immense evidence that azithromycin also equally work well. But only one condition where azithromycin being bacteriostatic, it does not penetrate the blood-brain barrier in scrub encephalopathy. Only one bactericidal agent is the drug of choice, that is doxycycline. So duration of treatment 7 to 10 days. So case fatality rate varies from 5 to 10%. Early diagnosis is very important. Otherwise, there will be complications. The child may die because of complications either by primary or secondary complications due to the organ damage because of the vasculitis. Finding of SCHAR almost confirms the diagnosis and treatment. So what is the research they say? We have experienced this scrub typhus, an emerging illness from Odisha. 44 cases we have seen, and out of them, near about 50%, I will say 50% cases, we have seen SCHAR. And another case series in the scrub encephalopathy, it has been seen, all the cases, they remained well within 48 hours. Almost all of them became normal, and we have switched over to oral doxycycline. So what is the take-home message? Dear doctors, scrub typhus is a very common in our community, pan-India. High index of suspicion in all cases of fever without focus. Here, 2-3 days back with Dr. Santanu and all our East Zone, we have been having spectator of that fever module. The module says any fever without focus or fever of unknown origin, you have to bring one DD of one differential diagnosis of scrub typhus. Fever not responding to routine antibiotic. One has to keep antenna on that it could be that. Unexplained fever with rash or swelling, hepatosplenomegaly, lymphadenopathy, all loss of sensorium, one has to search for SCHAR. Commonly go for IgM scrub. So IgM scrub is the routinely available, and it is one of the way we can diagnose. Doxycycline is the drug of choice. So SCHAR search is a must. In routine examination of every patient with continued fever, that is our need of the answer. And with this, I am ending my presentation. And after me, there are 2 postgraduates are there. One postgraduate is going to tell about a research case, and another postgraduate will be saying again another important case. So I thank all of you, and I'm thankful to my zonal coordinator. I can say Dr. Kalpana ma'am, Professor Kalpana ma'am, and Professor Santanu, and all dignitaries, those who are visible to me. And this scrub typhus is not uncommon, and because we in the coastal Odisha, we get a lot of cases. So that's why I thought it will be an eye-opener to all of you, so that everybody will love to search for SCHAR in their day-to-day practice. With this, I am staying. And any word from Kalpana ma'am, then we'll switch over to the next part. Kalpana ma'am, please.
Thank you, Dr. Sunil. It was a wonderful presentation. very insight, very learning points are there. We do get many cases of scrub. I mean, we have published neuro scrub, like it is, the main part of the brain is the cerebellum. So we have lots of cases of cerebral infection in the scrub typhus. So it's not uncovered now. It is one of the common disease nowadays all over the India, I think, and everyone will agree with me. So thank you for your nice presentation. And again, I'll request the chairperson to introduce the presenters, the postgraduates, and the topic, and ask them to present their cases.
Madam, Dr. Lalit, I think.
Yes, sir. Yes, sir. Okay, okay.
Yes.
Sir,
Yes,
there are some few questions. We can have 1 and 2 questions. Yes.
Dr. Kalpana, can I have one question, please?
Yes, sir. You can take 1, 2 questions.
I think very nice presentation, Dr. Agarwal, sir. Very nicely presented, very nicely described. And I have 2 things basically to ask. What are the role of steroids if CNS is involved or other complications are there, like in enteric? And secondly, what are the other differential rickettsial infections which were confused with scrub typhus? Suppose HCAR is not there. Is it possible? These 2 questions. Role of steroids, if there is complication, and of course, other rickettsial infection which we can confuse with this scrub.
Yes. I must admire Dr. Lalit ji that first question, how you are going to treat rickettsial encephalopathy, I mean scrub encephalopathy, what is the role of steroid? Now you know there is some role of steroid in viral encephalitis. There is role of steroid in TB meningitis. But there are two school of thought. There are many cases they have been treated with steroid, and there are many cases they have been treated without steroid. So steroid use in scrub encephalopathy is not superior to those cases, those who have not treated with steroid. So there is no guideline is that in rickettsial encephalopathy, the drug of choice being that no guideline says the usage of steroid. So now question comes, it is not detrimental. Like cerebral malaria, steroid is detrimental. But here you can use by your judgment, but there is no guideline that scrub encephalopathy to be treated with steroid. So that is 1.1 answer. Second question is that if the SCR is not there, now if I suspect it is a case of a rickettsial infection, one of the DD commonest in our locality, in our country is scrub. But if it is not scrub, it may be some other rickettsial infection. So back to back, there are 2 or 3 conditions are there. Indian tick typhus, that is one. Then endemic tick typhus. Then third one comes spotted fever group. So spotted fever group, these all conditions will not be picked up by IgM ELISA. That is for scrub only, because they picked up the Oriency antigen. But for that diagnosis, you have to go with Well-Felix reaction. If Well-Felix reaction will say the similar antigen will be cross-reactive with other antigen of Proteus. So OXK positive, then only we can say scrub. If other antigens are positive, it may be some other rickettsial infection. So what I mean to say, whether it is scrub or whether it is non-scrub rickettsial disease, it is the high index of suspicion when we do not know that the culprit is who. It is not bacterial or real typical bacterial disease. If we are getting any transaminitis or any anemia, thrombocytopenia, it is a high index of suspicion for the saving life. Empirical doxycycline, and you get miraculous improvement within 48 hours. So then definitely our diagnosis is rickettsia. Whether it is scrub or non-scrub doesn't matter. So these are the 2 answers to your question, Dr. Lalit.
Thank you, sir. Thank you very much.
Yeah, and thank you, Dr. Sunil, for nice explanation. But I think there is no role of a steroid in the scrub encephalopathy until unless there's only indication for the steroids for other causes like raised ICT and all. There's no guideline, no indication for using the steroids in a scrub encephalopathy.
Right, ma'am. Right, ma'am. Now I request my professor, head of the department, Professor Mishra sir, to call upon and introduce our postgraduate, Dr. Sweta Mishra. So now over to Mishra sir.
So good afternoon, everybody, and all the dignitaries on the IAP forum and Madam Kalpana Madam. Our presentation, next presentation will be by none other than Dr. Sweta Mishra, who is a brilliant student of final year of our institute and SCB Medical College, who will be talking on presenting a patient with recurrent pneumothorax, and where a diagnosis has been made that we will be going through it. It is a diagnosis of this congenital pulmonary airway malformation. So the message, take-home message will be given by none other than Professor Dr. Vijay Kumar Meher, who is also in charge of the critical care unit. So I invite Dr. Shweta Mishra to for the presentation.
Much, sir. Good afternoon, respected dignitaries. Myself, Dr. Shweta Mishra, third year postgraduate resident at SVM Medical College and Hospital, and I am going to start with the first case presentation. So this was a 2-year, 6-month-old male child born out of non-consanguineous marriage who was otherwise developmentally normal, presented to us with complaints of high-grade fever for 5 days, cough and cold for 5 days, and hurried breathing for 1 day. There was no history of similar complaints in the past, no history of prior hospitalization. The antenatal, natal, and postnatal history was uneventful. Patient was referred to us as a case of severe pneumonia. On examination, the airway was maintainable. The patient was maintaining a saturation of 85% with room air and 92% with oxygen via nasal prongs at 2 liters per minute. The patient was tachypneic. Respiratory rate was 70 per minute with increased work of breathing. On inspection, there was decreased movement of chest on the right side, and the percussion note was hyperresonant over the right side of chest. Breath sounds were diminished over the right lung fields. The peripheries were warm. Peripheral pulses were well felt. However, there was tachycardia. Patient had heart rate of 160 per minute with a blood pressure maintaining between 58th to 90th centile in all 4 limbs. The child was sick looking and irritable. Other relevant history, there was no history of failure to gain weight or recurrent cough and cold requiring hospitalization, suppressed suck cycle or forehead sweating in infancy, no history of past nebulization, allergy, atopy or asthma in any family member. There was no history of contact with a case of pulmonary tuberculosis or any accidental foreign body ingestion or cough and cold or similar complaints in any family member. So after our primary assessment and thorough history, we came to a diagnosis of right-sided pneumothorax. We did a needle thoracostomy in the second intercostal space along the mid-clavicular line and bubbling was present. So we ordered an emergency X-ray. As we can see in the radiograph over here, the right hemithorax appears hyperlucent with decreased vascular marking. The collapsed lung margin can be seen over here. However, the trachea is in the midline and there is no mediastinal deviation. Chest X-ray confirmed pneumothorax, but the patient had unstable vitals with tachycardia, tachypnea, and increased work of breathing. So we went for an emergency thoracostomy with intercostal drain placement, which was done in the 5th intercostal space along the anterior axillary line with supplemental oxygen via nasal prongs at 2 liters per minute. So any patient presenting with non-traumatic spontaneous pneumothorax, there can be two different types. Primary pneumothorax is when, even after thorough investigation, there is no underlying lung disease. We say it's secondary pneumothorax when it occurs as a complication to an underlying lung disease. The most common can be due to infections like pneumonia and tuberculosis. Some airway diseases like cystic fibrosis, asthma, airway obstruction, post foreign body aspiration can also lead to pneumothorax. Certain congenital airway malformation like congenital pulmonary adenomatous malformation, CPAM, congenital lobar emphysema, connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome, and interstitial lung diseases can also present with pneumothorax. Then our patient, who was a 2-year-old male child with no significant past history, with no history of failure to thrive, presenting with high-grade fever and cough and cold, the most common differential diagnosis that we thought was pneumonia. However, in a 2-year-old child, we cannot rule out airway obstruction due to accidental foreign body ingestion. And but congenital airway malformation, we did not think of it because usually with in conditions like CPAM and CLE, children present in the early infancy or in the neonatal period. So we went ahead and did the initial investigation. The TLC count was 7,500 with neutrophil of 44.8%. The hemoglobin was within normal limit, 12.6 gram per deciliter. CRP was 7.2 milligram per deciliter. The total platelet count, RBC, were within normal limits. We sent for blood culture and it came to be no growth. As we can see in this radiograph, it was done on day 2 of ICD placement. The right side of chest is still hyperinflated, and we can see a radiopaque patch in the hilar area. So we stuck to our initial diagnosis that was pneumonia with a ruptured nematocele. We continued with injectable antibiotics. By day 3 of ICD placement, the air column movement decreased and the repeat X-ray saw an apparent improvement. So we removed the chest tube and we continued the antibiotics for 14 days and the patient was subsequently discharged as the tachypnea improved. This was the initial presentation in July 2023, where patient was diagnosed as a case of right-sided pneumonia with pneumothorax. This same patient presented again in December 2023 with similar complaints. This time X-ray was repeated and again it showed right-sided pneumothorax. But however, this time the patient was comparatively vitally stable. So we had to evaluate the patient for recurrent spontaneous pneumothorax. We planned for a CT scan, and in between that, we managed the pneumothorax conservatively. So our CT scan report came, which revealed large cyst with multiple internal septation in the right hemithorax arising from the right upper lobe, suggestive of type 4 congenital pulmonary airway malformation. Complete collapse of the right upper lobe and partial collapse of the right middle lobe was there, and the right hemithoracic expansion with contralateral mediastinal shift. Atelectatic parenchymal band was seen in the left lower lobe. The patient was immediately taken off for surgery. Right thoracotomy with upper lobectomy was done and a cyst of 7 by 7 centimeter was extracted. The patient was shifted to PICU for 5 days and post-surgery the patient subsequently improved and was discharged. The patient is now doing well and is under our regular follow-up. So cases of congenital pulmonary airway malformation or CPAM, it was previously called congenital cystic adenomatous malformation, consists of hamartomatous and dysplastic lung tissue mixed with normal lung. It is a rare congenital pulmonary disorder occurring in 1 to 4 per 1 lakh births. It can be macrocystic, single or multiple cyst with cyst size more than 5 millimeter, or microcystic with cyst size less than 5 millimeter, and can be diagnosed prenatally by ultrasonography. However, most patients present in the newborn period or in the early infancy with respiratory distress and recurrent respiratory tract infections. This was a research paper published in Indian Pediatrics, where they did a 10-year retrospective chart review of 48 children with congenital lung malformations. And they found as congenital lung hypoplasia the most common cause of congenital lung malformation, followed by cystic pulmonary airway malformation, CPAM. So the CPAM, though it is rarely reported, but it is definitely one of the most common congenital lung malformations. This is another study done on 172 cases of CPAM, where they found that the mean age of presentation of CPAM was 48 months, and the children less than 6 months, mostly they presented with acute onset respiratory distress, and older children presented with recurrent pneumonia. So apart from chest radiographs, symptomatic patients should be evaluated with CT scan to distinguish CPAM from other anomalies which can mimic CPAM. For example, like congenital diaphragmatic hernia or bronchopulmonary cyst. So CPAM presenting as pneumothorax is a rare presentation, and the persistence of pneumothorax despite an ICD placement should raise suspicion. And it has been classified by the Stocker's classification into 5 different types, starting from type 0 to type 4. But type 4, as our patient was diagnosed, is usually associated with atypical presentation like pneumothorax, and it is also associated with malignancy. So early surgical resection is the definite treatment. These are few case reports that we found where patients with CPAM presented with recurrent pneumothorax, just like in our case. So my take-home message is, any patient presenting with spontaneous pneumothorax and emergency thoracostomy is a life-saving procedure, irrespective of the etiology. CPAM can present with pneumothorax in early childhood, and patient presenting with recurrent pneumothorax should always be evaluated for the secondary causes. And CPAM, once detected, should undergo immediate surgical resection, as there is high chance of malignancy. Thank you.
So now I request Professor Vijay Kumar Meher to sum up and give the message to the house.
Thank you, Dr. Sweta, for presenting nicely this interesting case of a type 4 CPAM who had a very unusual presentation. So every case is different and we learn from each and every case. So in this patient, this was a case of surgical case, but it presented to our emergency room. And this is very usual that all the surgical cases like this congenital long malformation, they come to the emergency room initially for stabilization and they are not being diagnosed. So our duty is to pick up the case, stabilize the child and send the patient for diagnostic evaluation and treat the patient and refer the patient for surgical management. So this is what is usual in this case is that this child presented to the emergency room with the respiratory distress. He had decreased air entry on the right side, hyperresonant on the auscultations. Chest X-ray was fortunately available. So X-ray was done, pneumothorax was suspected, and a needle thoracostomy was done in the second intercostal space. And this was a life-saving procedure in the emergency room. Whoever is there, forget about any diagnosis, this has to be done. And here I want to tell one thing is that needle thoracostomy in a suspected cases of pneumothorax is required even though X-ray is not available. And nowadays, point of care ultrasound is available. If it is available, you can use that to find it out that at the bedside, you can know that it is a pneumothorax. And afterwards, intercostal chest tube drainage. Again, I stress one more thing that fifth intercostal space is the site for insertion of an intercostal chest tube drainage, which was done in this case. Okay. Then another few things is that in the X-ray, there was no mediastinal shift. There are certain clues are there. There was no mediastinal shift in the chest X-ray. And so a point of care ultrasound might be helpful in this type of cases. One. Second thing, this patient present with fever, cough and cold and rhinorrhea. So many times this we think that this could be some infective etiology, but what happens in any child with this type of presentation having a congenital long malformation, the parents usually brought to the emergency room whenever there is some increase in the distress. So usually they remain in a compensated stage, and when they have some upper respiratory tract infection or something like that, then they usually come to that. That should be kept in mind. And this patient was presented at 2.5 years of age. We usually suspect congenital long malformation when the patient present with respiratory distress at early infancy. Usually they present at early infancy, like 6 months, 4 months, 6 months. And if you get some hyperlucent shadow in the right side or left side, any side of the lungs, then you can think that there could be congenital long malformation. So it is an unusual case who presented very late, 2.5 year of age with features suggestive of pneumothorax. So the management and the year was very correct. And at this again present at 2.5 year of age, it is not also possible to do a CT thorax in all the cases of pneumothorax because in a the resource limited settings, such as it is usually not possible. Yes. So thank you again, Dr. Sweta, for presenting this nice case. And you have also mentioned certain review literature where recurrent pneumothorax is a usual presentation of type 4 type of CPAM. So over to Professor Mr. Sir for the next case.
Can I ask one question, sir?
Yes.
Sir, this is a late presentation of the congenital malformation. Is there any antenatal scan done for the mother? So usually it is presented in antenatal.
Yes. Yes, it is a good question. I am giving answer to this. In our Cuttack, we have got a advanced center of fetal medicine. And there is a fetal medicine consultant who has diagnosed 29 cases of CPAM over last 4 years. That is from Moment Child Care Advanced Fetal Medicine Center. And all these 29 cases, many have been treated antenatally with steroid successfully, and those who have not been treated and followed up in repeat scan, and those who have continued to have solidification or this pulmonary airway malformation till birth, they have been referred to good centers like AIMS Bhubaneswar, like our institute also. Some of those cases have been operated and now they are healthy children. Now they have grown up to 3-4 years. So we have already successfully diagnosed by antenatal scan 29 cases of CPAM. the new name, congenital pulmonary airway malformation, which was previously called CCAM, congenital cystic adenomatous malformation. So this is the new name, CPAM. Thank you.
Is there any chance of natural resolution, sir? Natural resolution?
Yes, there is chance for resolution also. Because on follow-up scan, many cases resolve and many cases also respond to steroid given to the mother. Thank you.
Can I ask one question, sir?
Yes,
please.
Very nice case. It had the ultrasound and CT been done on the first setting, and then the diagnosis would have been made at the outset, in the first step, when the child was admitted first time? Or it could still have been missed in that ultrasound? And the CT could have been planned in that setting also, in the first, when the child was admitted?
Exactly, because it was emergency. And at that time, POCUS was not very much developed. Now we have developed POCUS, point of care ultrasound. After giving treatment, after receiving, we have got emergency experts like Dr. Vijay and myself. We have done this course on POCUS, and also other students are doing that. And so we have developed our emergency care. Then only we can diagnose them early, suspect them early. Because in the odd hours emergency, this decision sometimes there is very difficult in taking a decision about treatment, because priority to save the child.
I want to say the take-home message is that ultrasound should be done in any pneumothorax by that.
Exactly. Now long ultrasound or ultrasound of the thorax is the modality to be done on point of care. That is POCUS, point of care ultrasound. In every case, particularly a referral center like us, where we are getting so much of burden of cases, and we have got also 24 postgraduates each year. So we have got total 72 postgraduates, and also senior residents, large number of senior residents.
I do agree, Dr. Lalit. The one thing is that because the child presented in an infective manner, I mean fever.
Sir, you have become muted.
You muted.
We missed the diagnosis. Yes, we missed the diagnosis in the first time when the child presented. I mean that the child presented with fever, distress, and it was diagnosed radiologically pneumothorax. A tube given, the child improved and went back. It was the real story of this child. We never thought it could be underlying pathologies there, because we missed that because ultrasound was not done. So as of now, since then, anybody who comes with pneumothorax, we are going for ultrasound.
But yes, that's a good take-home message. And the second thing I want to know, the child once was discharged after ICD, child did not have anything. He was totally normal.
But sir, in the emergency room, putting a needle and putting a chest tube drainage is not going to harm the child if there is a suspicion.
No, I'm asking after the discharge, the child was normal.
No, total normal. And normal till December. The child came 7-8 months totally asymptomatic.
So this is the story.
What my approach is, this patient comes to ER. If I have a point of care ultrasound, if I diagnose a mass lesion, that I may hesitate to put a needle.
Yes. But there are certain cases of CPAM also, when they came with a additional pneumonia component, at that point of time to save the child, the needle has to be there. Because that is again, the decision has to be taken on then and there. Whether it is presenting as a CPAM or it is having associated pneumonia causing the problem. So there are two things.
Whenever there is a tension pneumothorax and the patient present with shock or there is a mediastinal septic, it is mandatory to keep a needle.
Right.
And put a chest tube.
Sorry to ask, is there any in the team pediatric surgeon?
Yes, sir. Not now.
We have
in our institute.
Sir, we have 6 MCH Department of Pediatrics with us.
Sir, actually this is the usual presentation for every CPAM, because it always accompanies with some infection or some pneumonia or some complication. So usually for the first time we miss it, then subsequently we diagnose. It is the sad story for because in first go we never suspect some congenital anomaly might be sitting on it.
The child was 2.5 years old.
And the side,
it is very unusual.
2.5-year-old
child.
So this was a little unusual, and we learned from this case, and that's the reason we wanted to put to the everybody, so that this thing may not be repeated by us or by anybody. So thanks.
Now I remember one 8-year-old also presented for the first time with this congenital anomaly. So it was very unusual to know it in the first go. Then we investigated and we got the, finally we got him resected and the child is fine.
So thank you, Dr. Swarupa, and thanks, Dr. Sweta, for your nice presentation. Now I'll call upon Dr.
Yes.
Sir, please.
Now the second case presentation will be done by none other than Dr. Ashish Das, who is also the final year postgraduate of our institute. So he will be presenting on recurrent acute kidney injury, presenting as atypical hemolytic uremic syndrome. So it is a very rare case, which we at SVPPG Institute of Pediatrics, we have got our division of pediatric nephrology. So where we provide a lot of services, including dialysis, hemodialysis, and also CRRT. So we have got 17 beds, and also we have got attached to intensive care. So we are providing service to whole of the eastern zone, because a lot of cases are being referred with AKI and kidney problems to our institute. So we are going to present by Dr. Ashish Kumar Das one case. So now the mic to Ashish.
Thank you so much, sir, for your kind words. So good afternoon, all the dignitaries in the dais. So I'm Dr. Ashish Kumar Das from Sardar Vallabhbhai Patel Postgraduate Institute of Pediatrics and SC Medical College, Cuttack, a third year junior resident. Today I'm going to present a case which is all about connecting the dots. So let's go to our patient. So our patient is a 7-year-old male child belonging to Khordha district of Odisha without any history of consanguinity, and the mother, being the informant, presented to us with chief complaint of vomiting for 4 days, pain abdomen, passage of mucous stool, and reddish discoloration of the urine for 3 days with decreased urination for 1 day. The patient had a past history of similar complaint, I would say, around 3 years back, where the patient developed AKI, and the patient successfully got discharged as a case of AKI secondary to AG with severe dehydration. And now the patient has no significant family history, developmental or antenatal history, and all the anthropometric examination are within normal limit. So we admitted the patient and did the primary assessment for the patient. In primary assessment, the airway was maintained with saturation of 99% in the room air. The patient had a respiratory rate of 22 per minute without any use of accessory muscle of respiration. The patient had a heart rate of 100 per minute with BP being 116/70, which came into 95th to 95th plus 12 centile as per age, sex, and height of the child. And that came under stage 1 hypertension. And the child was conscious and oriented. And on exposure, the child had some pallor with periorbital puffiness. So after assessing the child, we admit the child, and on day 1, the child developed oliguria. So we did the urine output monitoring. The antibiotics were started in the view of dysentery, and the BP was controlled by using amlodipine, and routine blood, urine, and stool samples were sent. On day 2 of hospitalization, all those reports came back, and we saw anemia, thrombocytopenia, and on the peripheral smear examination, we saw fragmented cells, cystiocytes, helmet cells with reticulocytes count being 4%, and the RFT was skyrocketed. The RFT value, so the blood urea being 233.7 milligram per deciliter, with serum creatinine value came to be 7.1 milligram per deciliter. And the urine routine microscopy examination showed plenty of RBCs with only 3 to 4 pus cells. On day 3 of hospitalization, rest of the investigations came back, and it showed DCT and sickling tests to be negative, with G6PD activity present. CRPQ was within normal limit. The MPICT was negative. Dengue NS1 was negative, with PT, APTT, and INR value was within normal limit. So to corroborate our diagnosis, we sent some additional investigations. So from these investigations, C3 value and ANA value was within normal limit. HIV, HBsAg, and HCV was negative. Anti-complement factor H antibody was within normal limit, but the LDH was 2,730 unit per liter, and haptoglobin level was below the normal range. So from all those clinical picture and the investigation, we came to a diagnosis of hemolytic uremic syndrome with stage 3 AKI, as the eGFR was 7.08 with stage 1 hypertension. So during the stay of hospitalization, we transfused the patient with PRBC and RDP to treat the anemia and thrombocytopenia, and we performed 5 sessions of intermittent hemodialysis on the patient to improve the RFT parameters. But as the day progressed, as the child was suffering from persistent oliguria and hematuria, we planned to do the renal biopsy to get some additional clues to whether the child is only a case of HUS or there are some other entity involving in this case. So when we did the renal biopsy, we got the finding of thrombotic microangiopathy with predominant glomerular involvement, as we can see here. And this picture also confirmed our diagnosis to be a case of HUS only. So during hospital stay, as we managed the patient, the platelet count gradually improved, the blood urea and creatinine parameter gradually become normal, and the child got successfully discharged. But again, the child presented after 1 month. So in this presentation, the child had pain abdomen for 5 days, reddish discoloration of the urine, and decreased urination for 3 days. So this time we thought of ruling out the other causes, and we did the routine investigation which showed anemia with blood, urea, and creatinine parameter again got skyrocketed with plenty of RBC in the urine routine microscopy. And this time we did the PNH clone to rule out the paroxysmal nocturnal hemoglobinuria possibility, but the PNH clone was absent. And the patient was managed conservatively and the AKI gradually started resolving. So why the child is landing up in recurrent AKI with hematuria in all these years? So to find out that reason, we started connecting all the dots. So now let's go back again. At the first presentation, the child was of 3 years of age with normal TPC, and the child presented with AG and a case of AKI. At second presentation, the child was of 7 years of age. The child presented with diarrhea, hematuria with features of acute kidney injury and features of anemia, thrombocytopenia, and the child was stamped as a case of hemolytic uremic syndrome. At the third presentation, that is almost 2 months later, the second presentation, the child presented with hematuria and AKY, but there is no history of diarrhea, but there was anemia without any thrombocytopenic feature. So to connect all these dots, we plan to perform a genetic study. So when we performed the whole exome sequencing, we got the deletion at exon 14 level, which is the gene that is CD46 gene that is responsible for occurrence of the disease that is called as atypical hemolytic uremic syndrome. So we finally reached to a diagnosis of atypical hemolytic uremic syndrome due to CD46 mutation. So what is this? The CD46 is a membrane cofactor protein, and it is a cofactor for complement factor I, and it is helpful in the degradation of the C3b and C4b. So this aberrant protein either results in the decreased cell surface level of CD46 or an impaired ability to control the alternate complement pathway activation on the host cell. So how will this child will present? It is generally an early childhood onset, but the child has a favorable kidney outcome, but the child will also land up in frequent relapses, and there is a very low rate of recurrence with kidney allografts. So after knowing all about this child, now let's see, this case was published in the journal in July 2023, and we also find similar cases in 2 different journals. One is Indian and other one is foreign journal. So after knowing about our case, let's go to the approach to a case of hemolytic uremic syndrome. From the clinical feature, we will send the lab parameters to suspect it a case of hemolytic uremic syndrome, and we will get generally hemoglobin level of less than 10 gram per deciliter, cystocytes level of more than 2%, LDS level of more than 450, or haptoglobin level of less than 30 milligram per deciliter, with platelet level of less than 1,50,000 with features of acute kidney injury. And before stamping it as a case of hemolytic uremic syndrome, we should rule out the infection like malaria, dengue, and other signs of sepsis that can cause AKI. And also we should rule out the possibility of thrombotic thrombocytopenic purpura. After ruling out these things, we will stamp it as a case of HUS. Now let's go to what are the etiologies of HUS. The etiology being the most commonly associated, that is Zika toxin associated HUS, that we will suspect when it is associated with bloody dysentery. It can be occur by following a pneumococcal infection that is called as pneumococcal HUS, which has features of pneumonia, and the culture and antigen will again suggest the presence of pneumococcal HUS. Then after that, it can be also due to cobalamin C deficiency, where we will find the elevated level of total homocysteine in the blood, or there will be MMA CHC gene mutation, or it can occur due to other infections like HIV, HPSAG, HCV, or other infections like EBV, or it can occur following a secondary cause, that is SLE or Aplar syndrome or drug-induced HUS, or following a hematopoietic stem cell transplantation or any solid organ tumor transplantation. Or when we will rule out all of these causes, then we will land up in the diagnosis of atypical HUS. And for the evaluation of the atypical HUS, we will do the C3 or the complement panel or the CD46 analysis by flow cytometry, or we can do anti-factor H antibody, or we can do genetic screening as we did for our child. So if any of these coming to be positive, will be stamped as a case of complement mediated HUS. But if we won't also found any of these positive, or any of the evaluation won't suggest anything, we will stamp the case as a case of unexplained HUS. And we will again review the probability of occurrence of the TTP and the probability of cobalamin C deficiency associated HUS. So after knowing the evaluation of the HUS, and I would like to give a carry home message that the clinical picture of loose stool, hematuria, and AKI should always prompt towards a diagnosis of HUS. But the recurrence of the AKI with hematuria indicates the etiology being other than the infectious cause that we are usually dealing with. The complement-mediated HUS is an extremely rare case, but it can be diagnosed, and early diagnosis will be helpful in the management and the better prognostication of this disease. Thank you so much.
So thank you, Dr. Assis, for very clear and continuous presentation. So now I hand over mic to Dr. Lipika Nayak, our assistant professor, to give the carry home message about this case.
Thank you, sir. Thank you, sir, for your good presentation. Myself, Dr. Lipika, I am assistant professor in SC Medical College, Cuttack. To summarize this case, this is a 7-year child present with complaints of hematuria, blood in stool, pain abdomen, and with a past history of admission at 4 years of age as a case of acute gastroenteritis with AKI. And that patient was resolved completely at that time. And in this admission, patient with complaints and with investigation suggestive of features of microangiopathic hemolytic anemia with thrombocytopenia with the features of AKI. So we kept possibility of diarrhea associated HUS. So due to persistent oliguria and hematuria, we do a renal biopsy, and the renal biopsy suggested thrombotic microangiopathic features. So and the patient also has prolonged hospital stay for 15 days, and in that period, patient required 5 sessions of hemodialysis. And the patient was recovered well with a diagnosis of diarrhea associated HUS. And again, after second admission, after 2.5 months of the second admission, patient again admitted with complaints of pain abdomen, hematuria, and decreased urination. At that time also, we kept the possibility of HUS. So to investigate what is the cause of recurrent HUS. So from the third admission, we decided to investigate the HUS to find out what are the other etiology for the recurrence of HUS. So we plan to do genetic study and complement analysis. And with that investigation, we find out that it is suggests CD46 mutation. So my take-home message is, although HUS commonly present with diarrhea, if there is a recurrence of a diarrhea associated HUS, we should think beyond the common etiology. And currently, there is no proven therapy for HUS with a CD46 mutation to prevent its relapse. So plasma exchange will not help with HUS with CD46 mutation.
So thank you.
Can I ask one?
Yes, sir. Yes, sir.
Sir, this extreme nice case. In the initial diagnosis, peripheral blood smear itself, it shows there is a hemolysis, and there is a G6PD positive in the history, number 2. Then, by doing renal biopsy in a progressive recurrent cases like this, will it modify or change the diagnosis or treatment, renal biopsy?
Yes. So because of persistent oliguria and non-improvement of the clinical condition of the patient, to find out any secondary etiology that may cause HUS, so we have done the renal biopsy. Secondary causes like SLE, malignancy.
Like other part of rapidly progressive glomerulonephritis.
Yes, sir.
Right.
Yes, sir. Yes, sir.
So there are two etiologies. One is primary renal disease causing this, and the renal biopsy has been done to rule out any secondary, like any immunological disease, collagen vascular disease is setting in and causing recurrence. So that was the purpose. But it is not going to help us in modifying the treatment protocol. And finally, after 3, when the diagnosis has been made, and that child is deteriorated.
And what is the significance of G6PD positive in this child, sir? Is there any trigger?
Coincidental, sir. It was coincidental.
Yes.
It's incidental, right?
Yes, yes. It was
because that also will cause hemolysis and all the other parts.
But in our case, the presentation, AKI and all, it was more towards HUS rather than G6PD playing a role. So we thought it is a mere coincidental. So that's why what was the reality, we brought that picture, but we have not given importance to that.
So mostly diarrhea-associated HUS remain completely resolved. Only less than 5% cases depend upon hemodialysis. But due to prolonged critical course, we plan to do the genetic study.
It was just only eye-opener because the child comes again and again with the similar picture. That hinted us what is happening, why the child comes again. Once there is some improvement, then deterioration. Some improvement, then deterioration. That hinted us to go to the genetic aspect, and it came out to be with a genomic exon genomic study that came out to be that particular gene associated. And that's the reason we wanted to, on research background, our postgraduate is going to present, and one moderator we have thought of.
Sir, one more thing. As such, we don't have a treatment for that, but we need to prognosticate to the parents as well. And we have to give a answer, concrete answer from a tertiary center. We need to have the
final diagnosis.
So final analysis can also prognosticate the case also. We can plan what are the therapeutic strategy for that patient in future.
May I ask one question, sir? May I ask one question, sir?
Yes, sir. Lalitji,
yes, sure.
Sir, nice thing to learn about. Are there other causes apart from this genetic cause of recurrent HUS? And secondly, how can you distinguish HUS due to TTP and other causes? Can you differentiate basically?
TTP, sir, we have to do the Adam deficiency. We have to do that also.
No, you have mentioned one of the causes of HUS is that...
Sir, there is no features of encephalopathy here. So I don't think it is a case about TTP here. Only the kidney involvement is there.
Sir, one of the DD, Dr. Lalitji, one of the DD of HUS is TTP. But TTP is usually by default, they are having CNS symptoms. That is one. That is...
Sir, sound, voice. Please unmute.
Sir,
network issues.
Net issue,
sir. Again.
No. Boliye, sir.
Sir. Is it audible?
Yes.
Yeah, now it's audible.
Sir, there is a closed DD of any HUS is a TTP. But only point is that all TTP, they are having a strong CNS presentation. And this child was not having CNS presentation. And we have not thought of this because HUS is common in this age group. And TTP is a little on a higher age group. So that's why we didn't brought TTP as a DD in this case, particularly. So that was our point. And we inclined towards HUS kyun bar ho raha hai. That was the main aim. And that's why we gone for a genetic study. We found out that. Then we searched literature. And it is also having that similar cases are being possible when the HUS comes again and again. So that was the only...
In literature does not show, apart from this genetic cause, the complement, any other infections, repeated infections causing HUS, which you came out in literature. And other causes other than this genetic cause for recurrent HUS?
No, sir. We didn't find out that.
Okay.
We didn't find out that. Maybe, sir, but our search limited. We didn't find out that. But this much we have digged in, and we came out that this recurrence is due to genetic predisposition in that particular child.
Okay. Thank you.
Thank you very much. And we yes,
can I, sir?
Yes, sir.
Yes, sir.
Dr. Lalit, this is a known fact. We've had patients like this, HUS, genetics, and Adam, what he's saying. We also have almost more than 1.5 dozen patients seen by our nephro keep. So this is a non-genetics for recurrent HUS that is there. It's always, we used to think dysentery, Shigella and all. But nowadays they keep asking for a genetic if a person has again, and they also are predisposed to AKI and longer problems in that. Congratulations for a wonderful presentation. I had the opportunity to listen to both. I was mesmerized by the rickettsial, and my experience is a lot in rickettsial because of hepatitis. Do you ever see infections without transaminitis? Because all cases I see, maybe being a liver specialist, they come to me with transaminitis. But do you see infections without that?
Yes, madam. Yes, madam. Couple of cases. We have no exact figure, but couple of cases when they come with a mild form, just fever, splenomegaly. Just
so
fever,
most of the
mild.
time, yeah, that's what I wanted to say. Liver. I see everything through liver.
But when we don't get transaminitis, we really recheck our diagnosis. Because in most of the cases, we have to.
That's what I've noticed.
Yeah.
So I've had always patients like that. Yeah.
Yes, ma'am. In the initial phase of the
Thank you so much.
typhus, we may get fever. That is the infective phase. But once we enter into the cytokine storm, by the time the transaminitis manifests. So that's the reason, because liver expert. So transaminitis cases are going to you. So you see 100%, but we see maybe a lesser percentage to that. Thank you, Nilam ma'am.
Thank you, madam, for your input.
Excellent presentation. Excellent presentation. Enjoyed it.
Thank you.
Yes.
Thank you. Yeah, over to Shantanu.
Congratulations to Dr. Ashish. Very well presented, and also to Dr. Mishra. And I must comment the guidance from the seniors that has made them present such good cases. So I wanted to ask, what is the prognosis of atypical HUS? What will happen? Recurrence is expected to continue till when? And what will happen to the renal functions? Does it lead to end-stage renal disease, and within how many years? So is it known?
Sir, I have sourced one original articles. In that case, the CD46 mutation cases, there is no evidence of any end-stage renal disease. There is a frequent relapse, but the patient may go into spontaneous resolution. Till now, sir, we have got only this from the original articles.
So basically, during the periods of AKI, there should be good support. Otherwise, there can be mortality during those periods.
Supportive management patient can improve, sir.
Just like a collaboration finding that nephrotic syndrome, they keeps on coming with relapse.
Yes.
But supportive management will come out, and later on they may not have relapse. So just like that, but no experience much about this atypical, because we are not seeing more. This is the probably 1 or 2 cases we have seen.
The difficulty is treating each episode of HUS. The difficulty every time.
Yes.
So
there may be future role of some immunomodulators in a condition like
this. Sir, eculizumab is available, but immunomodulator, but it is not available in India till now.
Sir, there are 2 things are coming up in coming future. Now 2024, we are all members. By 5 years, 6 years up the line, there may be a genetic basis of each and every disease. There may be some map for each and every disease.
Some map for everything. Yes.
Yes. And Dr. Shantanu, as it depends upon the etiology also. Atypical HUS is varied etiology. Not only the genetic onset, maybe the other onset. So prognostication really depends on the individual case and the etiology where it can do the HUS.
My question was directed to this case specifically. So what would be the, how would you tell?
As
what
it is
would
a
be
genetic,
the outcome?
there's a as it's a genetic basis, so it is a chances of recurrence and all. So, no?
Yes. With your permission, Dr. Shantanu, Dr. Kalpana ma'am, we are having a very short video regarding our institute, and at the end, so that is time 3-4 minutes, we wanted to show you, and that will be our final. Yes, ma'am, permitted?
Yeah, if chair permits. Okay, no issue.
Okay, ma'am.
Sir, please. Dr. Jog, sir. Is it okay to give them 3 minutes?
I know. Of course, Jagdish, I think Jagdish is around maybe.
Jagdish, sir, are we allowed?
It is always a pleasure to see a video from your institute. Please go ahead.
Okay, sir.
Thank you. Thank you, sir.
Thank you, Jagdish, sir.
सर फिजिकली बुलाइए वहां पे.
हाँ जरूर सर जरूर.
ये तो वर्चुअल है.
सर एग्जामिनर करके बुलाते हैं आपको.
ओके, थैंक यू वेरी मच.
Physically come to the oldest college of India.
It is a matter of privilege to visit the institution and meet all of you.
Yesterday only I finished the DNB exam.
इसमें
Sound is not audible, sir.
आवाज नहीं आ रही है इसमें.
Sound you'll have to increase.
क्या हुआ? ओवर?
वीडियो में कभी ना कभी कुछ इशू हो ही जाता है.
We can unmute.
यही कह रहे हैं कि फिजिकली बुलाओ सर.
हाँ.
Google Chrome.
Several healthcare specialties.
Yes, nice sound is there, but no visual now.
सर आ रहा है. आप बोले ना थोड़ा इशू है ना.
Nurture and nourishment of their body, mind and spirit. They are the flowering generation of the entire world. As the mother of several branches of diagnosis, treatment and care, SCB Medical College and Hospital created a flutter in setting up a pediatrics unit in 1960. The institute was rechristened as Sardar Vallabhbhai Patel Postgraduate Institute of Pediatrics. The completion of Indo-Japanese Grantinet project in March 2007 facilitated the increase of beds to 260 with a projected bed strength of 356, comprising 40 beds of pediatric surgery, 21 ICU beds, 25 newborn beds. 20 newborn beds started functioning since the 24th May 2012 after the completion of Sakigopal project building. The present bed strength stands at 416. Established on 23 acres of land, the noble mission of this premier institute is to provide qualitative tertiary health care with modern life-saving equipments and provisions of intensive care unit for older children and neonates. To impart postgraduate study in pediatrics medicine, thereby producing more number of pediatric specialists in the state. To develop the institute to the center of excellence with regard to treatment, teaching and training in pediatric medicine, the contribution of UNICEF in the field of the service sector deserves striking mention. The UNICEF also provided incubators and other equipments for the premature and underweight newborns. The present moment as the steel point of transformation. There has been phenomenal progress in Sishubhawan. Of the new departments and the number of beds. The pediatric ward in SCB Medical College and Hospital continues to function with postgraduate teaching in addition to Sardar Vallabhbhai Patel Postgraduate Institute of Pediatrics or Sishubhawan. 24 students are admitted to the postgraduate course in pediatrics every year in the name of this institute, which has been approved by Medical Council of India. The existing diagnostic, treatment and teaching related units and facilities are the radio diagnosis, the ICU, SNCU, newborn unit, 10-bedded nutrition rehabilitation center. In addition, the special OPDs are high-risk newborn clinic, pediatric nephrology clinic, pediatric neurology clinic, pediatric orthopedic clinic, newborn follow-up clinic, follow-up OPD in district early intervention center under RBSK program. Doctors and nurses of the entire state. The State Newborn Training Center is manned by experienced faculties. This library in Sishubhawan has been a treasure trove for many aspiring medicos, researchers and students to build up a sound foundation in pediatrics. The master plan of converting SCB Medical College into an AIMS Plus Global Treatment and Healthcare Institute will definitely boost Sishubhavan to be all the more vibrant. This cherished dream of Honorable Chief Minister Naveen Patnaik will be a reality in the near future. Shishubhavan has a concrete plan to enhance the number of beds to more than 600. G+7 building showcases this galloping hope, braving all the odds and being tougher than the tough times. The dedicated experts, doctors and paramedical employees of this quintessential institution have been trying their best to keep the children hale and hearty. That's why this sterling institution has been a unique center of pediatrics, not only in Eastern India, but also across the nation.
Thank you.
Sir, it's over now. So, sir, we have done our job. Now comments from all of you.
Thank you. It was nice presentation, very nice video. So now I request, I think when it is over, I request Dr. Chinnappa sir to say a few words. Then I'll request Dr. Pramod Jog sir for your final comment.
Right. I think we are discovering new gems every week. And today was no different. Today was no different. I think we had a feast of wonderful clinical insights. We started off with the beautiful presentation by Dr. Agarwal on the scrub typhus. Very well brought out that the clinical signs are very, very important before you suspect anything else. The other two cases which were presented were just excellent. And I think the reasons why they were excellent was that the cases presented unusually. They were unusual presentations of common clinical problems, and they were picked up and diagnosed till the end. And I think it was very, very fantastic to hear how this progress is taking place in every corner of our country. So thank you very much from the department at Cuttack for this wonderful afternoon of real, beautiful, excellent academics. Thank you so much.
Thank you, Jagdish Chinnappa sir.
Thank you.
Now I request Dr. Pramod Jog sir for your nice. I'm waiting for your mnemonics and the nice compilation of the program. Whole program.
No, thank you. Actually, I will just modify what Dr. Jagdish said. When I had been to Odisha, I had visited that Chilka Lake. And he said the gems, I will say, the pearls from Chilka Lake. Okay. So, all those pearls which we saw in the afternoon program, it was an excellent afternoon. And I understood that this SCB Medical College, I was actually under the impression that it stands for Subhash Chandra Bose because Subhash Chandra Bose was born in Cuttack, and the early childhood of Subhash Chandra Bose was in Cuttack. But then this was like Sri Ramachandra Bhanja Medical College. Okay.
Sir, actually, the whole property was given by Sri Ramachandra Bhanja. He was the king, Maharaja.
So it was a great MCQ. SCB is not Subhash Chandra Bose.
That's why I was under that impression. But good that is clarified. Of course, Sardar Vallabhbhai Patel, SVP, I could guess it as a postgraduate institute, but commonly now known as Sishubhawan. That's good. And Dr. Prabhakar Mishra is a good friend of mine, and I am glad that he led the discussion from the front. And Dr. Sunil Kumar is the adrenaline of your department, I must say that. And as he has seen so many cases of scrub typhus in the coastal Odisha, he has elaborated it in a unique style of his. And he has elaborated more about this SCHAR. And I will remember that eyes cannot see what, mind does not know. But I must add to that mind will only know if they attend our academics with institution, isn't it? So that is important that the mind knows after this. And I could see variations of SCHAR below that, mala and the loin, the neck, the axilla, the genitalia, the inner side of the ear, and the tip of the penis, and so on. So different sites for SCHAR he elaborated, and also explained nicely the painless SCHAR, followed by the tender cervical node, vasculitis, the cytokine storm in the second week. And I'm sure, he also must have seen ARDS cases, which we also see in the second week as a part. So, then the investigations and the management with doxycycline. So this case of fever rash and the loss of consciousness, that is the scrub encephalopathy, it was a very, very good, I must say, information for all the listeners. And as Jagdish said rightly, both the cases were excellent. And the case of recurrent spontaneous pneumothorax was very well evaluated. And I know that, I had purchased this filigree silver jewelry from Cuttack. Cuttack is known for this silver jewelry.
And I am sure all the residents who presented, they are very good analyzers. So it's no wonder that the artisans there are doing a great job over there, and it is probably in the blood of Cuttack. And we could learn a lot about this non-traumatic pneumothorax, and the analysis that she made, that it could be related to either infection or the airway disease or the congenital airway malformations or the connective tissue or the interstitial lung disease. And then coming to that type 4 CPAM, we will remember some take-home messages, like particularly if there is persistence of pneumothorax despite intercostal drain, one should be worried. Number 2, surgical treatment has to be early, and emergency thoracostomy, the needle thoracostomy, even if the X-ray is not available. And the role of point-of-care ultrasound, which has become now available. And Prabhakar told us that he has diagnosed antenatally 29 cases, and that's a great thing. And I congratulate Dr. Shweta and also Dr. Ashish, who told us about that recurrent acute kidney injury following HUS. And the only point to remember that if recurrence is there, and every time you cannot think of HUS because of, the loose motions related story, then one should think of something different. And it could be like, complement mediated HUS. So these two cases have given many points to the listeners. I know that Odisha is a place worship for Lord Jagannath. And the spot is where the Krishna's heart beats, so that is the place. The Jagannath Puri is known for heart beating. So I pray God that, Lord Jagannatha nurtures the dreams of all the faculty, and he sparks the changes in the little hearts of children of Odisha. Thank you.
Thank you, sir.
Madam, good evening. From South End, I really congratulate my friend Sunil Agarwal and his team for a wonderful program, sir. It was really your presentation as usual, because we always listen to your lectures and all that, and your postgraduate and your HOD and Dean, all, and very well comparing by Kalpana ma'am. So hats off to my brother Santanu for bringing a very good event today. Thank you all. Thank you for giving me this job.
Thank you, sir, for your nice one.
Thank you, sir. Thank you, sir. And thank you, Pramod Jog, sir, for your nice compilation and the whole theme in a 2 minutes word. He has covered everything in his
yes.
talk. That's a wonderful thing. Now this is a time to say thank you to all. So I really thankful to the IAP for giving this opportunity to us in the specially stunned part of India, and to highlight our different medical colleges. I must thank Dr. Vasavaraja, Dr. Yogesh Parikh sir, Dr. Shantanu Dev, Dr. Pramod Jog sir, Dr. Lalit, Dr. Jalil, Dr. Singarulu sir, Dr. Ramesh Chaudhary sir from Jaipur, whoever joined from either directly or from the attendance list. I must thank all of you for making this wonderful journey of 1.5 hours academic with the institution. Is very insightful and very informative too. I also thanks all the OBs and ABs of IAP 2024, and I also like to thank the other dignitaries to have joined, and also the chief guest. Let's not forget our chief guest. He has nicely said everything in details about your college. Dr. Mohanty sir and our chairperson, Dr. Mishra sir, Prabhakar Mishra sir, has nicely conducted the whole program. I must thank you, sir, from my core of heart. And my sincere thanks for the dynamic Dr. Sunil for leading from the front and helping the others. And I also thank to mentors and the presenters of a postgraduate student. They have done their wonderful job. And I also thank the person who has given the dIAP platform.
Yes.
From, of course, the IAP, the man behind this, I don't know. So thank you for giving this platform also. And thank you all for making this a successful program. Thank you all from my side.
Thank you, madam. Thank you, dIAP. And all the...
Madam, the brain behind everything is Dr. Sahil Chinnappa.
Yes. A big thank you to everyone in SCB Cuttack from my side.
Thank you, sir.
Thank you, sir.
Thank you so much.
Looking forward to meet everyone at Cuttack.
Yes.
Looking forward to meet everyone
And
at
everything
Cuttack.
here is free. All
Next
free.
CB will be in the Cuttack.
At no cost. Including ICU care, everything is free.
All IAPians, those who are present here, are invited to Cuttack. And this team will host you. Yes.
Okay, thank you.
Your conference hall was looking very familiar to me.
No Sarkar scheme, everything is free, zero out-of-pocket expense. Patient is admitted, everything free. ICU free, all drugs free.
Yes, sir.
Patient, there is zero out-of-pocket.
Right, sir. Right,
that is
sir.
the great.
And special thanks to Dr. Jal. Special thanks to
scheme
Dr.
of
Jalil
Government
and
of
Dr.
Odisha.
Lalit to make it more interactive.
Yes, yes.
Thank you,
Yes.
thank you,
Yes,
thank you,
yes.
ma'am. Thank you.
Yes,
Thank you.
yes.
Thank you,
Thank
sir.
you. Thank you, everybody.
Thank you so
all.
much. Thank you, madam.
Thank you.
And
Bye-bye.
thank you to
Bye-bye.
Kalpana madam for nicely moderating the whole program in the absence
Yes,
of
yes,
our
yes.
national convener.
We missed Dr.
Thank you,
Priya
Kalpana madam
President.
also.
Dr.
Yeah.
Kalpana, ma'am.
Sir,
We
you have
missed Dr.
promised
Priya
to come.
Shivali.
Yes, yes.
Yes, Swarupa madam, I'll come.
Sir, you have promised.
Thank you and
I'll come,
goodbye.
I'll come. Yes.
Sure.
Bye-bye. Bye-bye, everybody.
Bye, bye. Bye, bye.
Bye, bye.
See you next time.